Well, good afternoon, and thanks for joining our Cardiac College online session today. This session will be devoted to diabetes medications as they relate to the heart. My name is Paul O. I'm the medical director in the cardiac rehab program, and it's my pleasure to join you again for another session in this online education series. A quick reminder that these sessions are really geared towards your education specifically. And if you do have some particular questions about your own situation, we'd ask you to connect in with your own healthcare provider. We do enjoy, however, a Q&A session as part of these webinars into the Q&A box that is part of this Zoom screen. So your menu at the top or the bottom of your Zoom panel will take you to that Q&A window. Here's a way that we might frame all of the different important interventions around living with diabetes. We know diabetes is critically important for persons with diabetes as well as persons with living with heart disease, given that 30 or 40% of us who might be getting to attention with heart conditions may also be living with diabetes concomitantly. Here is a quick acronym that comes from the recent version of the Diabetes Canada Professional Guidelines that asks us to remember these major domains in a protection checklist around vascular health or heart health. And it takes us from A, B, C, D, E, and S. To remind us that A stands for A1C, achieving a really good blood sugar level. We're going to talk a lot about that today, and this kind of frames where we're going to go with this in terms of medicines that can help us control blood sugar. But it also reminds us that there are many other important interventions that we may be undertaking or that are on our list of things to do, like getting our blood pressure under excellent control, reducing cholesterol down to levels that are healthy for our heart and prevention of any new vascular problems. There may be some specific medicines that are being used to protect the heart, and many of these should seem familiar to you, like A for ACE inhibitors or angiotensin receptor blockers, those medicines that can help smooth the linings of our vessels, lower blood pressure, S for statins to lower cholesterol, A for aspirin or other kinds of medicines that might impact on those platelets in our bodies to keep the blood, quote, a little bit thin so that there isn't so much sticking going on in our blood vessels. And then we're going to talk about these specific examples of diabetes medicines that not only benefit sugar control, but also have demonstrated benefit in persons living with heart disease. E, of course, although not important, not kind of low down in the priority list, I should say. E is very important, and of course will allude to the importance of exercise and healthy eating. And S, not to be forgotten, will be smoking cessation. But as we've indicated in our ABC lists, we're going to focus on the A today as the focus of education. So why focus on A or A1C or blood sugar control? Well, data like these that are shown on the screen talk to us about the relationship between sugar control that is shown across the x-axis versus the risk of heart disease or other bad things from happening. And in this panel that includes 10,000 people living with diabetes in their middle years, red denotes men and green denotes women. You can see that when sugar is absolutely normal, so this level way over here at the left would be for people who do not have any mention of diabetes or any semblance of diabetes, versus people over to the right side with abnormal blood sugar control and known diabetes. You can see that the risk of developing coronary artery disease over a period of decades goes up as much as 6 or 7 times if sugar control gets progressively abnormal. So up at these levels where sugar is up greater than 7% on average, then this is the highest risk category. And this is why most guidelines around the world, and including the ones in Canada, would say that if you're living with diabetes, the guideline is to get your sugar down below 7% over that 3-month average A1C measure. And if possible, without causing low blood sugar, we can move it even further down towards absolutely normal, where the risk of cardiovascular disease can be mitigated largely. So the call out here, the risk of cardiovascular disease rises as sugar control deteriorates. Healthy eating, exercise, and medication will help us move from the right-hand side of this graph down to the left-hand side. A lot of information about diabetes medicines are available in the Cardiac College and Diabetes College resources. If you link on to Diabetes College, you'll find the patient guide to help you live and thrive with diabetes, very similar to the cardiac one that we often focus upon in these sessions. But the diabetes one will also have a specific chapter devoted to diabetes medicines, and it'll cover off these three major objectives of what your diabetes medicines do, what are your diabetes medicines, and who can help with your diabetes medicines if needed. So if you want some extra homework after this particular session, we'd invite you to visit that Healthy University website, click on the diabetes tab, and find that manual, get to chapter 7, and review the diabetes medicines. But if you're here with me live or after the fact, we'll go through the highlights of this chapter together, as well as draw from some other resources to augment that material. One of the examples of ancillary materials that may be helpful can be pulled from another excellent companion website called Diabetes Canada Clinical Practice Guidelines. And this is where health professionals would turn to get the latest in evidence updates and guidance around clinical care. When you look into the particular chapter about diabetes medicine, you find rather complex tables like this one. And I pull it up for viewing, not for you to look at necessarily, because there's a lot of really small print and a lot of detail here. But what it says is that there are many options for medications. Medicines have different profiles, different side effects, and different kind of effects on blood sugar as well. And it's important for us to be aware of all of these different kinds of medicines and choose the ones that best fit your particular situation. So a particular class may be preferred or not preferred on the basis of effects on heart disease outcomes or cardiovascular disease outcomes. And the green boxes in particular, the dark green ones, may be our focus for the audience today, in that these particular medicines are the ones that probably have the strongest evidence for a benefit of the therapy, not only to reduce sugar, but also to improve heart outcomes for individuals living with diabetes. Another important consideration might be around side effects. So for instance, some medicines, because they lower blood sugar, may actually lower blood sugar too much. And that can occur with medicines like insulin. We'll talk more about that, as well as other older medicines that cause the pancreas to squeeze out more insulin. It causes the pancreas to secrete insulin. So these are called secretagogues. There are also effects on weight. Some medicines help us lose weight, while other medicines will cause us to gain weight. And, I don't need to tell you that it would be more favorable for most individuals if we can actually have some weight reductions as opposed to weight gain as part of the story. And then for all medicines, we'll want to make sure that the sugars actually go down, particularly when these medicines are used in combination with other therapies like metformin. And then each medicine will have its own unique kinds of side effects that are very important to consider. And then finally, the right-hand column, the very far right, speaks to the cost of these medicines. Now, Some of us will have good medicine coverage through our provincial health plans or through private health plans through our employers. But I do recognize that some of us may be paying for medicines out of pocket. And the considerations on how expensive these medicines might be could be a swaying factor in terms of choosing one or the other. Okay, so point well taken. There are many options for medicines. They all can work well on sugar, but they have different profiles and different side effects that may lead us to one or the other. Okay, so as we're calling this out a little bit more discreetly, here are some other options or some other considerations that might inform us. If we were meeting together to decide on which medicine might be the appropriate in your situation, there's all that data in the table. As we said, the effect on blood sugar. The other specific things that I might ask is what is the effect of these medicines on the heart or on the kidneys? The side effects, low blood sugar, weight gain. And then the formulations of medicines might also be important. Like, does this come as a pill or is it an injectable therapy? And in certain situations, we may prefer one over the other. Once again, in the Diabetes Canada guideline, there is this nice flow chart or algorithm that guides us in terms of where we want to go with our choices of therapies. And at the top of of this figure, it says at the time of diagnosis of type 2 diabetes, everybody should be engaging in healthy behavioral interventions. So in our ABCDE checklist, E stood for exercise and eating healthy. And indeed, that is emphasized at the beginning and also throughout the course of persons living with diabetes. But you also note that the large part of the real estate on this slide is really devoted to guiding medication choices. And depending on how far above target our sugars might be, we may elect to choose just one therapy or wait a little bit, start with 2 therapies, or start something more intensive if our sugars are quite high or if our body systems have been rather compromised. Then we may want to get the sugars under control very quickly by using potent agents like insulin. As we start off with the therapies, we're going to anticipate we'll probably need more than one therapy at some point. And if we start thinking about the different options from that complex table or from the bullet points of therapeutic considerations, one of the important questions that we will ask is, do you have heart disease? And if the answer is yes, then we're going to be pushed to use certain kinds of agents. We'll continue to ask those other questions around blood sugar control, not too high or not too low, and these other considerations that we've covered off as well. So the tables and the flow charts from the guidelines can help us along this way. Let's now take some time to go through the different options in terms of therapies, and maybe this will tweak you to ask some particular questions about your situations. For most people living with diabetes, the first line, the first step in terms of the therapeutic cascade will have us using a medicine like metformin. This is generally the first choice for people with type 2 diabetes because it is safe, it is very inexpensive, and older studies would suggest that there are some possible heart benefits from this. We've known about it for several decades, and thus we've got a lot of comfort in using this therapy. It works by making your body respond better to the insulin that the body already produces. So it makes us more effective in handling sugar, processing it, and getting it to places where it needs to go. Metformin also has an effect on the liver, and the liver is the site where there is some internal glucose production on an ongoing basis. So this is a nice way of balancing out the body to some extent. One of the major side effects of metformin, particularly early on in therapy, is that it may cause some upset to the stomach and bowels, so that we'll experience some nausea and diarrhea. For most people, this gets better after a week or two as your body gets used to it, and then you'd be okay with that. It also tells us then that we should typically start with a smaller dose of metformin rather than jump up to a high dose right off the start. Because it doesn't cause extra insulin to be released into the body, it is associated with a low risk of low blood sugars and does not cause weight gain. So there's many positive aspects to this older medicine, and this is why that is often used as the first line therapy. A second line option, an older one, are these medicines that are called the secretagogues or sulfonylureas. In Canada, the most common example might be a medicine like glyburide or glucagonlike as two options. These medicines help your pancreas release more insulin. I think of it like if your pancreas was kind of like a sponge, then this is a medicine that makes the sponge squeeze and push out extra insulin into the body, particularly when we're trying to respond to a meal. So this extra bolus of insulin helps to bring those sugars down. But because we've squeezed out this extra insulin into the body, a possible side effect will include low blood sugar, and that can be quite dangerous, especially for older individuals or folks who don't have a lot of reserve in their body. So we do have to be cautious about that. And what's also been shown is that because insulin by itself, when it's in the body, causes a change in metabolism and causes kind of growth within the body. So we can actually experience some weight gain if one starts this kind of medicine. Because of these attributes, this is slowly falling out of favor as a class of medicines. Not to say if you've got good success with this therapy, because it does lower blood sugar. And if you're in good balance with it, then it still might be a very good option for you. But as I said, especially for seniors, we're tending to drift away from this therapy in favor of other ones that might have a slightly more favorable side effect profile. So as we've said, if metformin and healthy behavior changes are not enough, then we may consider some other medicines beyond the sulfonylureas. And the class of medicines that came out about a dozen years ago were these medicines called DPP4 inhibitors, dipeptidyl peptidase inhibitors. And here are a few examples of them, and you can recognize them because they end in gliptin. I forgot an L here. So linagliptin, alogliptin, sitagliptin, saxagliptin. These medicines work to lower blood glucose by increasing insulin levels after meals, lowering glucagon levels that has an impact on the liver that raises blood glucose. So it's trying to reset the balance somewhat in a hormonal profile. They tend to have a somewhat modest effect on blood sugar. So medium effect sugar, don't cause weight gain, low risk of hypoglycemia, but not terribly potent either. So they're an okay option, but maybe there's actually something better that we might use. And this is where newer therapies that have emerged over the last 5 to 10 years really come in. So there's a group of medicines called SGLT2 inhibitors. And gosh, I think you're learning that in medicine that we develop complex names for different kinds of therapies based on where they work. And when there's a bunch of initials, that means it's working on a very specific target in the body. In this case, this is a sodium glucose loop transporter 2 mechanism inside one of the kidney tubes. We'll explain a little bit more about how that functions in just a moment. But by blocking this transporter, these medicines eliminate glucose into the urine. So that's really kind of an interesting thought, that we can actually get rid of some sugar, excess sugar that might be in our body. When you put sugar in urine, that unfortunately that creates an environment that may breed the growth of infections that are undesirable, such as yeast infections or Candida infections in the genital areas. It may promote the development of bacterial urinary infections, may cause you to need to urinate more and more frequently, and may also cause low blood pressure, because if you're losing sugar and water and salt, then that can kind of squeeze down your blood volumes and make you feel like you're low in terms of blood pressure as well. That can be both a good and a bad thing. These medicines are associated with weight loss, which is a positive, and they have a low risk of excessively low blood sugar. So that's also quite a nice positive. And here in stylized fashion, we're going to show you where the SGLT2 transporter kind of sits. So if we've got sugar in our body, all the sugar and indeed all the blood flow eventually ends up at the level of our kidneys. And you can see at these tiny little blood vessel networks, there's also a network of collection tubes that eventually make urine that comes down this white colored ureter here. Sugar is usually filtered by the kidney through these tubules, and then it gets reabsorbed. Under usual conditions where our sugar levels are pretty normal, we've got this nice recycling kind of mechanism. But some smart folks figured out, well, if you actually block that transporter, though, you could actually cause sugar to get dumped into the urine, and there it's going to emerge if we bother to test the urine on the other side when that SGLT2 transporter is blocked. So that quite neat as a mechanism of therapy. If we lower our body sugar, we can lower our fluid, we can lower our blood pressure as a result of that. And I'll show you in a moment about the effects on the heart by doing so. Another group of medicines that can be quite powerful and have favorable effects on both blood sugar and other parts of our body are called these glucagon-like peptides, GLP-1 receptor agonists. Means that these are therapies that work on a particular receptor in our body to increase insulin levels, which helps lower blood glucose, lower glucagon levels, the hormone in our body that makes sugar go up. So again, restoring the balance very, very nicely. Most of these medicines have been injectables, but there's one new one that can also be taken as a pill now. In addition to the effects on blood sugars, they can also have an effect on digestion and slowing things down and reducing appetite. And for that reason, some of these medicines are actually being looked at and used as ways of promoting weight loss as well. Some people will lose as much as 5 or 10% of body weight. So it doesn't necessarily transform everything completely, but some people can lose a significant amount of weight. These are associated with a low risk of overly low blood sugar. Some people still need insulin therapy as well. And, this is the 100th anniversary of insulin this year, celebrating the successes of Sir Frederick Banting and Charles Best in the University of Toronto laboratories. Amazing accomplishments when we think about the last century. Well, we still have insulins today, not exactly the same ones that Dr. Banting used way back when. We've got more purified, more scientifically engineered therapies, but still the same idea that insulin works is like the OG of sugar therapy, right? This is the way that the body handles sugar. When you put insulin into the body, it helps us process the sugar, take it into the cells where it belongs. Some people who have type 2 diabetes need insulin therapies as well, because over time, for some individuals, the pancreas just kind of wears out and there isn't enough insulin production. Or some people have such high levels of resistance in their muscle cells and fat cells, for instance, that the amount of insulin that's floating around just isn't enough to trigger the responses that are necessary. So injecting an extra amount of insulin may just do the trick at getting sugar levels down. We're going to talk about different kinds of insulins, but some people use a single therapy. Some people use mixtures, and some will use very long-acting ones that may be used through the day or through the night. This table from the Diabetes Canada guidelines highlights a couple things again, that there are many kinds of insulin. The old ones from Dr. Banting's day would have been derived from animals like pigs and cows. Now we've got humanized versions of all of the insulins that are generated through recombinant technologies. And basically they're divided into bolus insulins, which are basically short-acting ones, and basal insulins, which are long-acting ones. And this kind of simulates what's trying to go on in the body, that we have short-acting insulins that come on very quickly and then wear off after 1 or 2 hours. And that's kind of the typical response of our insulins in our body after we eat. And then there are basal insulins that kind of hang on for many, many hours, even days in the case of some of these very long-acting insulins, to give us a certain baseline level of insulin so that our bodily processes can chug along in the way that they were designed. So you could see the setup for this is that often we'll use the combination of the two. And that's what these next couple of figures are going to try and show us, that if we think about insulin levels in response to a meal, the bumps in the graph indicate what our internal insulin level responses would look like after we eat each time. When we inject insulin with needles and syringes through prescription medications, then the idea is that we will try and offer up a similar level of insulin coverage. And we might do that by injecting a long-acting human basal insulin once a day. That's what's shown in the green, or the purple for an analog kind of insulin. And then we might also try out these mealtime insulins that we might take with breakfast, lunch, and dinner as one example. With these two different kinds of insulins, that we'll try to get to a better match of what our internal insulin profiles might look like. So some of you may be on insulins and you're on these different combinations to try to match that sort of thing. And then there are these sort of pre-mixed insulins that typically are about 30% short acting, 70% longer acting, that try and give us a profile like our internal systems. But you could see from this human premixed or analog premixed, they're not bad, but they're not quite perfect in duplicating the shape of the peaks and the valleys of insulin profiles that might be in our bodies naturally. But these are ways of approaching insulin therapy, and adjustments are made to get good sugar controls, typically after meals, as well as first thing in the morning, and then over the course of days to weeks to months. So where things have gotten interesting over the last several years is the impact of diabetes medicines on the heart as well. We often, or over the years, we focused on choosing diabetes medicines that typically would lower blood sugar and really use that as our focus. But nowadays, we are thinking about diabetes medicines for their other properties. And studies like this one that was published in 2015, this was one of the first ones that kind of turned the corner in our thinking. For orientation, I'm going to show you a few of these kinds of slides that report on major outcomes from big clinical studies in people living with diabetes. We're going to highlight a particular therapy, in this case called Dapagliflozin. This is an example of one of those SGLT2 inhibitor drugs, the ones that block that sugar transporter in the kidney and cause you to dump sugar. So Dapagliflozin was compared against placebo in several thousand people. These folks were followed in this study out to 48 months, and the bad things were counted as they occurred through the course of the study. In this case, dying from heart disease, having a heart attack, or having a stroke. I think you'd agree with me. Those are bad things that can happen. And it's interesting that the investigator teams wanted to look at these events sort of in distinction to sugar control. The sugar control really wasn't the goal of the study. It was looking at these cardiovascular events. So if we focus on the black line, first of all, you'll see that this line goes up smooth and steady and very straight over the course of the 4 years, so that on average, about 5% of people every year would experience one of these bad things: a stroke, a heart attack, or dying from heart disease. The interesting thing was that for the folks who received, instead of placebo, they received empagliflozin, the new diabetes medicine, not only were their sugars a little bit better, but the risk of developing one of these heart problems was also substantially better. And in this case, it appeared that folks only experienced these events at a rate of 3 to 4% per year. Overall, there was a 14% reduction in the risk of bad things happening if you received the therapy. So this really revolutionized the thinking about the choice of diabetes medicines for people living with diabetes who have a heart event or at risk of a heart event. Choice does matter in this case. To give you some information that this was not isolated to a single therapy, that if we look at the cousin to empagliflozin, in this case canagliflozin, similar kind of structure with thousands of people randomized to either the drug or to placebo and followed for several years, and then bad things were looked at over a period of time. In this case, cardiovascular death, heart attack, and stroke. So same kinds of events. Once again, a 14% reduction in bad things happening if you took canagliflozin instead of placebo. So very interesting. And that kind of led to those recommendations that choosing one of these SGLT2 inhibitors was indeed a very good thing. For other kinds of therapies, Liraglutide is an example of a GLP-1 therapy. So this injectable treatment that kind of enhances the effects of insulin, lowers the effect of glucagon, helps one lose weight. So these kinds of therapies, very similar kinds of findings in thousands of people. The folks that received the injection of liraglutide versus placebo, 13% lower risk of bad things happening when you receive the active therapy. And then Dapagliflozin, which is the third member of the SGLT2 family, was shown more recently in studies of persons with heart failure to improve cardiovascular death or hospitalization for heart failure. So it has a broader effect on improving outcomes for people living with heart disease, preventing heart attack, preventing stroke, preventing heart failure by choosing to use these kinds of medicines. And if I draw your attention, for instance, to the highest risk group here, persons with heart failure with impairments of heart function, receiving placebo, versus the solid red line are people with heart failure with reduced heart function who received dapagliflozin. In this case, very dramatic reduction of 38% in bad things happening with the therapies. So these are very exciting kind of newer outcomes that do inform the guidelines. If you want to hear more about guidelines, then as I've indicated, it's a great place to visit. Diabetes Canada Clinical Practice Guidelines. That's guidelines.diabetes.ca. And you'll see this information for healthcare providers if you wanted to look at some of those slides, but also for patients and thinking about patient resources that might be available in a couple of different languages. And of course, I alluded to the fact that we do have our own resources at the Healthy University, and in particular within the Sun Life Diabetes College. You can get your guide there, look at the medicines chapter as well. So now is the time when I would very much enjoyed looking for your questions, if you have any, and I will do my best to provide some answers. I don't see anything that's appeared during the course of the session. I thank you for your rapt attention then, but I'll give you a few more seconds to pose any questions that you might have. If you don't have any right now in the moment, or if you're watching this kind of on your own time and something does come up, please do feel free to pose a question through your rehab case manager or rehab supervisor, who can then route the question to me or to others who might be able to address your question. Okay, I don't see anything new that's come on, and I won't belabor this part any further. I'll just ask you or invite you to follow us on social media platforms like Twitter, and our handle can be seen at healthyu_TRI. So please follow us and get updates about Cardiac College online sessions, as well as new modifications. There will be a lot of new great stuff coming to the Diabetes College website over the next several months. So social media would be a great way of finding out about that. And then we hope you will join us once again for the next in the installment in the Cardiac College online series. Next Wednesday at 1 p.m., my colleague Renee Canitas will be taking us through diabetes, health behaviors to prevent long-term complications. Thanks very much for sharing this time with us, and I hope you've enjoyed the information. I will take the one question that comes in, and it's about an older class of medicines that I actually didn't touch upon formally, about medicines that were previously prescribed, like pioglitazone or rosiglitazone. About 15 years ago or so, these were new medicines that came onto the market. They were very interesting because they did have an impact on glucose production in the liver. And then they kind of fell off out of favor. On the one hand, they were quite good at sugar control and also had some positive effects on cholesterol and blood pressure. On the downside, however, it was seen that many people who were taking this medicine had a tendency to fluid retention. So they gained salt and water, and some people ended up tipping over into heart failure. So, in contrast to the new therapies that seem to be very positive on the heart, these ones seem to be kind of negative towards the heart. So they fell out of favor and have largely been replaced by some of the newer therapies that we're seeing these days. Okay, so thanks for the question. Hope that answered the item. And once again, thanks for joining in today, and we'll look forward to seeing you at one of our upcoming sessions. Take care and stay well.